Up next, we have Dr. Natalie Rasgon, who is professor in the Department of Psychiatry and Obstetrics and Gynecology and the director of the Stanford Center for Neuroscience and Women's Health. I also want to let everyone know we actually have 34 people logged in remotely, so it's not just the group here, which is why we're asking everyone to speak into the mic, because it's being recorded for those who are watching across the country. Thank you.
UK too. Can you show me this, how to hold this? Well, good morning. Thank you very much for inviting me to this very exciting actually program. So I'm here very peripherally, and I'm presenting data from my lab in collaboration with Dr. Rees, which I would say is not just an evidence of our intellectual common-mindedness, but also familial ties, because Heather Kenna, who actually pioneered and published that data, relates to the Dr. Rees's lab very innately through her romantic ties. So this is all labor of love, I would say. So basically, I will take you a little bit further in this road of questions which were so elegantly posed by the previous speaker with regard to the POI and reproductive function in women with Fragile X premutation. And I'm not going to actually dwell at all on a Fragile X, because I understand that that would be completely inappropriate of me. But by the way, how do I do it? I'm not very AV. Is that the right way? Yeah. Okay. So I will skip those slides and talk to you about what was the premise of the this pilot study. We decided to kind of look at the potential interrelationship between the reproductive function and depression, because it is well known that women with Fragile X premutation have, as you heard, and you know well, significant reproductive dysfunction. Up to 25% of women have it, various stages. I think it is kind of a continuum, and I think that that's what you kind of heard right now, that there is really a spectrum of dysfunction, which may be coming from the POI at age 28 to early age at menopause. So also, there is a suggestion of the higher prevalence of the mood disorders in women with Fragile X premutation. Those studies were not as well established, but certainly there were enough suggestions in the literature, and so we decided to look, is there any potential correlation between the reproductive status of women with Fragile X and their depression? One of the reasons to even suggest that would be to understand the relationship between the hypothalamus-pituitary adrenal and hypothalamus-pituitary gonadal systems in the specific regulation of the ovarian function. And so we do know that in women who have even treated major depression, age at menopause is about 5 to 7 years younger than those who are not having depression. So even the presence of a treated depression is potentially a risk factor for kind of early cessation of reproductive function. So clearly we understand the potential reason for women who are carriers, Fragile X carriers, who have kids with the disease for being depressed, etc. And the question was really to look at the spectrum of the illnesses, psychiatric morbidity, I would call it, because that what really was of interest to us. Depression is a very kind of a muddy term. So the only study we found in the literature at the time we started the study was looking at the interaction between the reproductive function and psychiatric history used self-report. And so our study was actually looking at the structured clinical interview which was administered to each woman participated in this study. So this is the kind of a graphic, cartoonish way to ask that question. And we looked at 46 mothers of affected children in Dr. Rees's a larger NIMH-funded study of children with fragile eggs and their unaffected siblings. And we looked at the reproductive history, lifetime and current pattern of menstruation, use of contraceptive or hormone replacement therapy, medication, supplements, and general medical history. So this is the slide, this is from just the general description of the sample. I just want to point out to you the distribution of menopausal status women in this sample of 46. So the 22 of 46 were in postmenopause, and you just heard that the definition of postmenopause is the depletion of oocyte pool. Well, clinically, it's fairly easy to detect because it's at least 12 months since the last menstrual period. And that's a significant number of women who were already in postmenopause at that time. Their mean age, however, was 50 years old, as you could see. Perimenopausal women were in minority, actually, and 17 women were not in menopause. So in a way, it kind of not ties well with what you saw in the previous presentation, albeit in a larger sample here, that women develop POI. None of these women actually had POI. But again, what I'm trying to kind of bring into discussion potentially is that all of it is on a spectrum, really. It's really not a very uniform, isolated defect in ovarian function. What we found is that the mean age at menopause for the menopausal women was still 45, and otherwise no other significant of interest variables in this group we found. We did find very high prevalence of lifetime psychiatric comorbidities. So something we actually did not expect to see. We kind of thought we'll see more of the reproductive dysfunction rather than a psychiatric pathology, but we found that about 74% of them had at least one lifetime episode of depressive or anxiety disorder. Now, this is not self-report, this is a structured clinical interview. And 43 of them had comorbidity between the two. So I think it's kind of sobering to think, and again, back to this notion of pleomorphism in the psychopathology as much as a pleomorphism in a reproductive dysfunction. So these are not, and understanding the small sample size, these are not uniform disorders afflicting it, but they're clearly some signal to suggest that a vast majority of these women have psychiatric disease. So when we looked at the average age at menopause, as I said, it was about 5 years lower than regular national average, quite significant difference. The permutation length, however, did not differ between the postmenopausal and premenopausal women. And so what we did in this analysis, and I want to caution you on that, is that we removed the perimenopausal, those small sample of perimenopausal women, because we wanted to be very pristine from the reproductive standpoint. We really looked at those who were before entering perimenopause and those who were in postmenopause. My speculation, which we can definitely check, is that if to take women on a spectrum from the late premenopause into postmenopause, we may find very different association. Also, permutation length was not associated with the age at menopause for the group of postmenopausal women. However, the history of depressive or anxiety disorder was associated with a significantly longer permutation length, even adjusting for age. There was no interaction between the menopausal status and the severity of the autistic or adaptive behavior in children, etc. So we did not find the significant interaction there, but I think that we may be looking at the small signal which would prompt us to potentially expand the study into more precise evaluation of a larger sample of women and really look at the biomarkers of reproductive function in a longitudinal design and to see how those are affecting the mood disorders. So with that, I will stop. And if you have any questions, I'll be happy to entertain them. Yeah.
Hello?
I was just wondering if you had any thoughts about this group of women being different in the sense that they are women who have children, just by nature of how they got into the study, and if, so they probably were, more able to, I'm sure some of them had, in vitro, but for the most part conceived naturally, so that if this group somehow is going to differ from a group who hasn't been able to have children?
It's an excellent question, actually. So yes, of course, because this is a convenience sample, right? We were looking at the participants in one of your studies, but I would suggest that it would be very interesting to compare the rates of mood disorders among women who have POI, established POI, like in the previous report, and women who are mothers of children with Fragile X, and to see if there's anything else which might be different. I think in this case, we're looking at potential interplay between the cellular aging, chromosomal aberration, and the stress of caregiving, right? So there's a number of issues. I do believe that these, as you said, by virtue of being mothers, had a different reproductive function, but at the same time, we can't really say it with certainty because they still had an age at menopause by 5 years younger. And that could be due to depression. So we cannot really untangle the effect of depression in this sample. And again, that only prompts the further evaluation of a cleaner kind of a sample and seeing if you take people with the primary POI versus people with a primary depression in the Fragile X carriers. Yeah.
So I have a question from Edna Antonia. In patients who have strong clinical suspicion for Fragile X but don't test positive for the repeat triplets, can you test for FMR1 function or point functions leading to a non-functional FMR1 protein?
This is totally not to me. I can only talk about their reproductive function. I'd be delighted to answer that part. Dr. Rees, would you like to?
I think it was a general question
to
all of the... Yeah.
Mike, do you want to answer that one?
I can take a shot at it, and I can just tell you that it's very difficult to get routine testing for sporadic mutations in FMR1. If you go to a genetic center, for example, at Emory University and Dr. Steve Warren, they can do that sort of testing, but it essentially involves sequencing of the gene, and it's very much more involved and more difficult. So it's not routine by any means. But the good news is that the number of sporadic mutations appears to be very small. There are some microdeletions that involve FMR1, that cause Fragile X-like symptoms. But the actual number of mutations in the protein itself that have been described is very small, like 2.
So I just wanted to provide an anecdote and maybe just a little bit of an important concept. The anecdote is I was talking to a mother of a child who had Fragile X syndrome recently. She said she had been on the internet and she said, and she had the premutation, and she said, "Oh, now I understand everything about myself." And I said, you know, you might not want to go there, at least in complete lockstep, because as you point out, the directionality of all of these and the other factors and the sample bias that we have, just like everyone else has, in terms of people who come here, who are curious, who may have higher socioeconomic strata, who may for a variety of reasons, may be more prone to insightful, related depression. What did I do wrong? So there's all this interesting interaction there that that I think you stated it very well, Natalie. We just don't know yet. And I will tell you, I like to, so in the same way I like to say, vaccines don't cause autism. I always like to say that whenever I'm at a meeting. P-mutations, and I know you basically intimated, don't cause depression or anxiety.
Of course not.
They're associated with it. And it's a fascinating question because for me, and I know you and I have talked about this, that is it really one of the possible fascinating directions may be that you have premature ovarian insufficiency and you subject a young brain to that hormonal milieu, and that actually may be one of the precipitating or risk factors. A brain of someone who is in their 50s may be, I'm not saying that women's brains are ever ready for menopause, but I've seen a 25-year-old who has menopausal symptoms with the premutation. And I can't imagine that a 25-year-old brain is ready or expecting that type of hormonal milieu. And maybe that's one of the precipitating risk factors that leads to what we call, as you say, the phenotype of depression and anxiety.
So I completely agree with you, Ellen, but I want to kind of tie what you just said with the previous, again, report from the reproductive endocrinology, because what almost sounded to me in that is like if there is an early young brain with a premutation and there is a reproductive maturation, and so in a couple of these patients, that's why I was asking, so they did start menarche at 13, which is a normal time for the development of the maturation of this HPG axis, and yet there's almost some kind of a reversal of that with the ensuing of a secondary amenorrhea and deprivation of the brain from any ovarian influence at that point, because there is that is a overproduction of the gonadotropins, and there's nothing coming from the ovary. So the question is there almost like an involution of reproductive function which may trigger and sponsor the subsequent changes in the limbic system and the hippocampus, et cetera, which, as we know, are very tightly connected to the other parts of the brain. So the question is, where does it come from, right? And I would say that even more kind of intriguing to me is the fact that, as we discussed also, women with a full mutation have normal reproductive function. So what does it really mean? We have really kind of a paradoxical continuum, right? They have, with a premutation, they may have almost an involution of reproductive function, and with a full mutation, they have normal reproductive function. So that I think it deserves really a very, very significant attention.
Yeah. I want to make one other comment. Oh, I see the sign. So the one other comment is that the first study we ever did, before we even knew about the gene that leads to risk for Fragile X syndrome, was in probably a large group of women with the premutation. Maybe we had one or two women with the full mutation in there, maybe. But we compared them to mothers of children who had comparable level of developmental disability. And so the punchline was, yeah, there were really high levels of depression and anxiety, but guess what? They were really high in the other group as well, which doesn't mean that there's not a biologic risk in this other group as well. It's much more heterogeneous and messy maybe than Fragile X, but it just, that environmental part, as you emphasize, can't be overlooked. It has to be factored in as well.
Thank you.